Alrighty, everyone. So welcome. This is going to be the assessment and release of psychiatric patients in EMS. So for everyone that has taken this course already, you'll basically be repeating it. However, it's going to be an awesome way for us to be able to really get a good grasp on how we deal with psychiatric patients here at UEMR specifically, as well as in general EMS as well. Alrighty, so the course overview. So basically, what we're looking at here is the part one of the course is going to be a general approach to psychiatric assessment. So this is in general how we de-escalate, how we consider scene safety, important differential diagnoses to consider and then rule out, and then suicidal, homicidal patients. This will be just the general approach, and this is kind of applicable to anywhere in EMS. As well as then part two, which is the psychiatric patient dispositions. This will be specific to UEMR. So how we deal with psychiatric patients and what we're going to deal with it. Okay. So for instance, it'll be dealing with the criteria for psychiatric patient refusal, the criteria and process for the patient release to law enforcement, and then also the documentation that's going to be required. Alrighty, so going to the goals of the assessment. So this is looking back at part one, and it's going to be looking back at part one and looking at the general approach to how we or why we want to focus in on the psychiatric assessment. So at the BLS level, we don't really have many treatments for psychiatric emergencies. A lot of times ALS treatment is going to be medication, and obviously we don't have that medication. But what we can do is really complete a good assessment and rule out any major medical issues that could be causing or masking as a psychiatric emergency. Okay, so psychiatric symptoms, as we'll learn later on in the course, can be taught or masked by a bunch of different stuff, and we need to be able to recognize, hey, is this a medical emergency or is this just a psychiatric emergency? Okay, do they have actually something that could kill them? And we'll learn a bunch of different things, but or is this just simply due to their psychiatric condition? So to kind of recap, our goal is to essentially rule out anything else other than a psychiatric issue, and then we want to make sure that the only thing that could be causing the psychiatric related symptom is the actual psychiatric issue. If a patient has a schizophrenic issue, we want to make sure that the only thing wrong with that patient is the fact that it's due to the schizophrenia. It's not because of the hypoglycemia. It's not because of a head injury. It's not because of something else. It's just because of that schizophrenia. So at the BLS level, we can really rule out a lot of these things and really get a good grip on our patients on whether or not they are truly having a life-threatening emergency. Okay, so in your handouts, which if you're watching this after the fact will be included on e-learning, but if it's in the moment, that you look at your handouts. And on this is included in our medical protocols, our psychiatric assessment protocol. Okay, and so we'll basically be going over this today and how to look at it and be basically, over here it says assess vitals and history, rule out differentials. So we'll go over that. We'll go over what it means by a full assessment, and it'll go over de-escalation. We'll go over APAL stuff. We'll go over capacity to refuse transport. So this is going to be the basis of the course today. So we're going to follow each one of these, okay? All right, so the first thing we're going to step on is the de-escalation part, okay? So the first thing we got to look at is the patient calm and collected. If they're not, the first thing before we can attempt our assessment, we have to de-escalate, okay? We have to have a calm and collected patient to be able to effectively assess them. So the first part, obviously, de-escalation. If de-escalation is successful, then we can go ahead and start our assessment. If it's unsuccessful, we need to activate the fire department, get them en route, medication, or in this case, they may need to be medically sedated, and then obviously ensure law enforcement's on scene. Our scene safety is the priority here as well. Okay, so we're going to talk more about de-escalation. So de-escalation, it's super important, and the reason why it's so important is because it allows us access to our patient. If they're yelling and screaming, and not enabling us to really have a conversation with them, then we are not able to effectively assess their medical history. So we need to be able to make sure that we're giving that patients the best shot of a proper assessment. Okay, so that's why we do this de-escalation protocol, is to make sure that we can get a good access to that patient. So with good de-escalation, we can calm them down. It's a good scene safety mechanism for us. It's going to provide the patient safety and us provider safety. But just as importantly, it's going to give us a good assessment access to that patient. So there are going to be many different methods, and we'll go over some, but each patient is going to respond differently. Okay, so you might have a favorite method that works, but that's not necessarily going to be the best scenario, because each of these patients are going to be responding on a different way to each different sort of method. Okay, so the general rule here is that if one de-escalation method does not work, we don't keep trying the same thing. Okay, try other methods. If the can won't open with that can opener, you got to find a different can opener. It's the same concept. You gotta be trying different stuff. Okay, so let's talk about some techniques then. So de-escalation in general, we kind of have two, really for us here at UEMR, kind of two best techniques that'll work the best. Okay, the first one is going to be reducing stimuli, and that's something that should be very easy for us to do. Okay, so for instance, let's change the location. So let's say they respond to they're in the library and there's a bunch of people around studying, and the patient sees that. They see how many people are around. Well, obviously that location is going to be, it's not helping their psychiatric emergency. Okay, it's not bettering their anxiety. It's not bettering their condition. So by us changing that, we're changing the dynamics of the situation, and hopefully that will help them at least calm down or de-escalate. Okay, so removing them from the location, get them on a wheelchair, get them on a stretcher, do whatever we have to do to get them out of the room, so we can, or at least change and find a quieter location. Other ones, removing unnecessary people on scene. So this is another good one, especially here in like apartment buildings, around dorm rooms and things like that. One of the freshman dorm rooms, they get crowded very easily with people. So if we don't need all the people in there, we don't need 5 officers in there. We also don't need the captain, the FTO, the in-charge, the attendant's friend. We don't need all those people in there. So while de-escalation is going, remove as many people as you can. Okay, if they're really escalated, they're super mad, they're super angry. Something that's a good way to do is send the highest provider in. For instance, let's say the captain or maybe the FTO. Send them in and get them to de-escalate with an officer. Okay, scene safety is a priority, but don't all send them in at once. Okay, and once we've de-escalated, once we've kind of got a relationship with that patient, then we can go ahead and introduce the rest of the crew. But having just that one person to get a key relationship with that patient and not having 30 people on scene is going to help us with this reducing the stimuli there. And it also helps to form that patient relationship. The next part is the verbal de-escalation, okay? Talking to your patient. So, we say here, focus on history and assessment, okay? Focus on your assessment and don't lead the conversation away from, well, what's got you feeling like this today? Oh, your girlfriend broke up with you. Oh, well, why did your girlfriend broke up with you? Oh, well, I hope it gets better. That's not to do with our history. That's not to do with our assessment. We're playing into their anxiety, and that's not necessarily the case or the approach that we'll want to take. Okay, so focus on their history, focus on the assessment, lead them away from what's causing the anxiety. We're not a counselor here, and we have to realize our role in this whole situation is to, again, going back to the goals of the assessment, right? What is the goals of the assessment? To essentially rule out other things, or to complete a full assessment, rule out medical issues. Okay, so when we go back here, if we're focusing on the history and assessment, that's helping us achieve our goal. Whereas if we're going into their psychiatric condition and kind of going on more of a counselor route, that's not necessarily helping us achieve our goal in ruling out medical emergencies. We're EMTs, we're not counselors, okay? Now, giving choices, okay, this is another option. So let's say that we have a guy in the library. He's freaking out, he's schizophrenic or whatever, or let's say they're having anxiety. Let's say we'll have the scenario is the patient's having anxiety. Well, they're yelling and screaming. They're saying, well, I don't want to do this. I don't want to do that. Well, and you as a provider can go, well, hey, listen, we've got 2 choices here. You can walk out with me, okay, and you can calm down, and we can walk out with me and we can have a good conversation, or the officer here is going to have to or at least detain you, okay, and that's going to be a lot worse of a situation. So we've got to be careful here that this is not a threat. We don't want to be threatening them, but giving them a choice. Or a different approach to giving choices may be, hey, listen, where do you want to go? Do you want to go out here? Do you want to go here? Or to change the location, right? Give them a choice on where they want to go. Or what can we do for you today? What do you want us to do? But giving them a set choice and not really letting them dictate the situation is important, okay? So whether it needs to be more of a authority tone, saying, hey, listen, we've got two choices. You can either come on with me, or we can get the police officer to do it for us. Or, because we're not threatening, we're just, this is the reality of the situation. Or we can then go ahead and do other things like giving them choices on where they want to go. Okay, and then setting limits is the last one. As you can see, this is kind of an escalation. Focusing on history and assessment, we're just talking to them. Now we're setting limits. This is saying, well, listen, you cannot yell and scream in the library. We are going to remove you from the situation, whether it's by choice or not. And if it's not, then that's going to be the police department. So you cannot yell and scream. We have to go. This is how we're going to do it. And so we don't want to come across as threatening, but we need to come across as firm. Meaning that we're not going to sit here and argue with you for 30 minutes about this. This is going to be, if you're yelling and screaming, this is not going to be the case. We're not going to go ahead and do this. We're going to move you out of here, whether it's from the police officer or from EMS, but we're not going to sit here and argue. Okay, so setting the limits is kind of the last ditch effort. Hey, listen, I want to listen to you, man. We've got to assess you. Come outside and we'll talk and have a good conversation. No, I don't want to do that. I don't want to do that. All right, well, now we're going to have to, I can't let you sit here and yell and scream, so what's the other option here? And that's kind of the approach that you should have. Okay, so if de-escalation is unsuccessful, it's not always going to be successful, guys, and it depends on your patient. If they're in a state of psychosis, de-escalation is really not going to work. So we got to activate Richardson Fire Department immediately. We may need to sedate here, especially in that psychotic state. Sedation is typically the route that we'll have to take. Now, and if RFD is en route, try to get as much of the assessment as you can. Obviously, if you can't, then, because of seen safety issues or something, then fine. But get as much history, get as much of the assessment done as can, so Richardson Fire Department have something when they get on scene. Get a history if you can. If you can't, like I say, it's not a huge deal. The rule here is, though, always maintain crew safety. Don't get a history at the expense of a crew member getting hurt, okay? Have the police department on scene, or never turn your back on a psychiatric patient. The other rules that we should approach this with, and hopefully we can get this patient the help that they need. Okay, so to recap, we haven't got a calm and collected patient, so we went over to this side. We've got the de-escalation. We've attempted that. That's unsuccessful, so we activated Richardson Fire Department and get them en route. Let's say we were successful. Now we're going to go on to assess vitals, history, roll out psychiatric differential diagnoses, okay? So we'll kind of go into this part here, okay? This is our patient assessment. So let's say the findings are normal. We're going to basically have to articulate that after full assessment, the patient presents with no condition that could reasonably be suspected of endangering the patient's health. So we have to be able to articulate this. And how do we articulate this? By doing a full assessment, okay? So let's talk about that. All right, so the patient history. And this is more specifically, and obviously go back to your sample, go back to your typical, your approach to getting a history, but this is especially or specific to psychiatric emergencies. Go back into the psychiatric history. Have you been hospitalized with this before? Your anxiety, that'll give you a very good indication whether or not how serious that anxiety patient actually is. How many hospitalizations do you have? Have you been to hospital before? And then, have you been diagnosed with any psychiatric conditions? Oh, yeah, I've been diagnosed with schizophrenia, anxiety, depression. Oh, okay, well, that gives me at least a route. And it will give me, if you've never been diagnosed with a psychiatric condition before, you've never been hospitalized with this before, but you're presenting with psychiatric symptoms, my red flags on whether or not they're actually having a psychiatric-only emergency, my skepticism will go up, okay? But if they've been hospitalized 30 times before for anxiety and they're having anxiety symptoms, then I can probably, with caution, at least attribute some of this to just having the anxiety. We're still going to do our assessment, don't get me wrong, but at least I can feel more comfortable articulating that this patient may just have the psychiatric-only emergency. Medications, another important one. Do you take medications for this psychiatric condition? Well, if you do, did you take them this morning? Or did you take them? Are you in compliance with the medication? Don't just ask about their psychiatric medications. Hey, did you take that this morning? Well, no. Okay, that's probably what's causing this right now. If they're not taking their psychiatric medications, then that's something that we need to be able to identify and rule out, okay? So ask them about their medication history. Sometimes they'll have them on them. If they are, then Google what they are. If you don't know what they are, it just gives you the tablet or something. We've had a couple of patients here at UEMR that they have a little capsule of their medications that they got to take at lunchtime. Well, if we don't know what the medication is, the patient's unable to tell us. Google the little medication thing, so we're able to know. Fun fact: we've had a patient where it was presenting as a psychiatric a patient, but it actually turned out to be he was postictal from a seizure. No one else. There was no seizure activity noted. Nothing else. The only thing that led us to be a seizure, the patient that was postictal, was because we had to Google their medications, and it turns out they were anticonvulsants. We got on the phone with the parents. They found out that yes, this was actually the patient was epileptic, had a bunch of seizures all the time, and has very long postictal states. So again, medications and investigating this is super, super important. All right, so psychiatric differential diagnoses. This is really, we have to memorize this, okay, guys? So everything on here needs to be memorized. This is really the crux of this assessment part of the course. Okay, so going through it. Hypoglycemia, all right? So our blood glucose below 70. Remember, our new protocols state that it's below 70. How do we assess for it? It's pretty easy. Obviously, blood glucose assessment, okay? So think about it. Hypoglycemia, this could be causing it. This is the really easy one and something that we should really do on any altered mental status. All right, so head injury. So a Cushing's triad presentation. We need to know this, okay? History of trauma, external signs, okay? Was there a mechanism of injury here? Pupils, what do they look like? Are they parallel? Are they not? Cushing's triad, okay? Remember, our heart rate decreases, systolic blood pressure increases, respiratory decreases, okay? So think about this. Are they presenting with those signs? Is this part getting worse as we go along? Because if it's getting worse, then the head injury is presently getting worse. So keep in mind the Cushing's triad is a very good thing to look at. Ingestion overdose. So drug, poison, something like that. A lot of times scene clues. Do we have evidence of ingestion on scene? Do we have a pill bottle? Do we have a syringe or something? History. Do we get bystanders? Did they able to tell us what happened, or are they the patient able to tell us what happened? Respiratory rate. Are they decreased? Heart rate is increased. Remember with opioids, we'll have a decreased respiratory rate. Heart rate's going to be an increase, especially with the stimulants and things like that. Pupils, okay? Are they abnormal, for instance? We have to be able to recognize this. Okay, other stuff. Hypoxia, hypoperfusion, okay? What is causing what could be causing this? And then the hypoxia and the hypoperfusion itself could be causing these psychiatric symptoms. Skin color. Are they having are they diaphoretic, pallor? Do we have a history consistent with shock? Do they have a mechanism for shock? Then hypotension, okay? Heat emergency. Look around. Is it a hot day? Is it, are you outside in 100-degree weather? Is the patient skin condition? Are they sweating? Are they not sweating? All these different histories. Infection, again, skin temperature and then condition as well. Seizure, postictal, bystander witnesses, do they have any seizure activity? Patient history, do they take medications? Do they have a bracelet on? Something that can tell us if they're a postictal or a seizure patient. Intoxication, this is another one, okay? Scene clues, smell, slow speech, decreased mental status, something like that, but it'll be another thing from bystander witness history as well. And then stroke, okay? And we're going to complete our stroke assessment, Cincinnati, and the LA motor, which is the secondary one. So the idea of this chart, guys, is you should be thinking on every single psychiatric patient. We should be at least going through this and rolling out each one. Do they have hypoglycemia? No. We did a blood glucose assessment. Do they have head injury? No. There's no signs of trauma. There's no mechanism. All their vitals are normal. Okay. Ingestion overdose. Well, there's no indication to think that. The respiratory rate's good. The pupils are good. Okay, great. Hypoxia. Again, skin color is good. No mechanism for shock. Vitals are normal. Heat emergency. Again, are we outside? Are they sweating? Are they not sweating? Skin condition, mental status. Infection. Again, is there a history of one? The temperature. Are they having an infection now? Seizure. Again, patient history. Bystander witnesses. Intoxication. Are there any signs for that? And then stroke, obviously, with the stroke assessment. So each single psychiatric patient, you have to think of every single one of these and be able to articulate that you ruled it out. Okay, so on your reports, guess what you have to rule out? No signs of hypoglycemia, no signs of head injury, no signs of overdose ingestion, no signs of hypoxia, no signs of heat injury, no signs of infection. You have to keep ruling this stuff out so I know you did a full assessment. Especially, guys, if you're releasing these guys to law enforcement, if that went through an APAL, I want this report to be amazing, okay? Releasing to law enforcement can always get hairy with litigation. Please, please, please write down all your ruling out of your differentials, okay? All of these should be on your report. All right, so we've articulated that after full assessment, patient presents with no condition that could reasonably be suspected of endangering the patient's health. Okay, we've been able to articulate this. So we've ruled out all of our differentials, all our vitals are normal. No, let's say they did have a psychiatric history of schizophrenia, for instance. Okay, so let's say they do, after all the assessment, we've ruled out everything, vitals are normal, but they have a history of psychiatric. The next question we have to ask ourselves, are they deemed to be a threat to themselves or others? Okay, so now we're kind of moving on to part 2 of the course. Well, not just yet. Are they deemed a threat to themselves? Are they suicidal or homicidal? Okay, so suicidal, homicidal patients. These guys, we cannot be scared of asking about this because we need to know, again, our role is to prevent serious injury or death. That's what us as EMTs do, okay? Well, if they want to commit suicide, if they want to kill themselves, we have to know that, okay? So, the first step, have to ask them. And it don't have to be all horrible about it. You don't have to be going, hey, you want to shoot yourself tonight? We don't have to be like that. But you can simply ask, hey, do you want to hurt yourself or others tonight? Okay, no? Awesome. Move on, okay? So, if yes to self-harm, find out their plan. Do they plan on shooting themselves? Do they plan on taking pills? Okay, and we'll return to that in a second. And if yes to homicidal, obviously we want to request PD. We won't want them to kill you as well. All right, so step 3, ensure that there is no evidence of them having done or attempted their plan. So this is why we ask about their plans, because we need to make sure there is no evidence of them having done this. So let's say the scenario, you're dispatched to apartment 31 for a welfare concern. The police department have requested you because there could be potential pill ingestion. You get on scene, you ask them, hey, do you want to hurt yourself or others? And they say no. Well, let's say that, sorry, my bad. They say yes, okay? So let's say they do want to say it. But they said, I want to kill myself, but I haven't done it yet. Well, if they want to kill themselves, are they going to be upfront with you about whether or not they've committed suicide? Let's say they took pills. Are they going to be upfront with you about it? No, because you're going to take them to the ER and save your life. So if they are homicidal or suicidal, they're not going to be upfront with you all the time. Okay, so ensure there is no evidence of them having done their particular plan. So let's say they have done the patient's friend stated that they took pills and they said that they are suicidal. We need to look around the apartment. Look for these pill bottles. Look for signs that they've done their plan. Because if they have, then that's an indication of us to request RFD and get them in route. Okay, we have to be able to articulate very, very well that they did not complete their plan. All right, we have to make sure that that's been done. Again, homicidal, request PD immediately. All right, so we'll go over another scenario. It's very similar to what we just did. You were dispatched to a 21-year-old female in the residence halls after PD has requested you for a welfare check. Police department called because a friend reports that taking pills or talking to the patient, she thought that the patient may have taken drugs with the intention of harming themselves. The friend did not witness the drug ingestion. Okay, so knowing this, you walk into the dorm and face the patient. What's your next questions? All right, so what are we going to do? Are you wanting to hurt yourself or others? Okay, did you take any pills? No. But let's say both answers are no. They're not wanting to take pills, and they don't want to hurt themselves, and they didn't take any pills. Their vitals are normal. Okay, well, what is the next step? There's no real complaint here other than the friend said that they took pills. The vitals are normal. The medical history is normal. Everything's normal. The pills, they didn't take pills. They didn't want to hurt themselves or others. So what's our next step? How do I know that this patient is telling the truth? And kind of going back to this step here, ensure there is no evidence in them having done this. Look around the apartment. Look in the trash. Look in the bathroom. Are there any empty pill bottles around? Okay, use your judgment and to see whether or not this patient could be telling the truth. Okay, we want to exhaust all our options when assessing this sort of patients. Okay, so ensure that they did not complete their plan, if that's the case. Again, going back to this is super important, guys. Use your scene to help you. Are drugs on the counter? Are there any containers full or empty? Drug paraphernalia, okay? Is there any evidence on scene that would contradict what my patient is saying? If that is the case, then you need to call RFD because they could have potentially taken pills, and we want to make sure that we can get them the help they need. Alright, so this is kind of moving on to part 2 of the course, psychiatric patient dispositions. Alright, so our policy. This is UEMR specific, guys. Refusals on psychiatric patients. So all psychiatric patients need or patient refusals are high risk and need the approval of a captain. To every single psychiatric patient, whether that be anxiety, whether that be if you deem the chief complaint is psychiatric in nature, a captain needs to approve it. And because we need to make sure that all of this stuff is met, okay, they demonstrate. So for us to get a refusal on them, guys, all the criteria needs to be met. The patient demonstrates full capacity. There's no homicidal, suicidal intentions. There's no evidence of self-harm or attention to self-harm. The patient does not meet any RFD upgrade criteria. And then the police officer gives approval, okay? The last one there basically saying that the police officer doesn't want to APAL them, okay? And we'll talk about APAL in a second. And then the last one there is a full psychiatric assessment is completed as per UEMR and Biotel. Well, actually, it's not Biotel anymore. This needs to be changed. It's going to be Dr. Tice's clinical practical guidelines, policies and procedures, and is the best judgment of the provider that the patient does not present with any signs or symptoms that could reasonably suggest a threat to the patient's health. Again, the clause here, you have to be able to articulate this, all right? So be very, very careful about that. And we'll keep going and we'll come back to this. Okay, so let's say the patient is deemed to be a threat to themselves or others. If that is the case, then we are going to request law enforcement to do an APAL, and we'll go over what that is. If they are full capacity, they're not a threat to themselves or others, we can sign a refusal of transport. If they do not display capacity, we have to activate RFD. Okay. So kind of going back over this, we have all these are our dispositions. Remember, if we try to attempt de-escalation, it's not successful, we're going to hand off to RFD. If we find that their findings are normal in their history, everything's good, or their medical history is good, their assessment's good, they're not a threat to themselves or others, full capacity, refusal. They are a threat to themselves, APAL. If they're not full capacity, Richardson. Okay, so again, guys, making sure we go over this very, very carefully is super important. All right, release of a psychiatric patient. There are 3 types of dispositions for psychiatric patients, and kind of what we just gone over. RFD transfer, okay, apprehension by police officer without a warrant, and then refusal of transport. Okay, so the disposition for an RFD transfer. Obviously, if any life threats recognized, okay, going back to the thing here. If their findings are abnormal to this assessment, okay, or know the patient may have a medical issue other than a psychiatric condition, activate Richardson, okay. Apprehension by a police officer without a warrant. The patient presents a reasonable threat to themselves or others, typically due to psychiatric issues, all right. There are no medical issues, only with the patient. Okay. Again, the police officer has to agree to this. Okay, they have to articulate whether or not they are. They have to articulate that the patient is a threat to themselves or others to detain them, and we'll go over what this means a little bit more. But there are no medical issues with this patient. Refusal of transport, again, clear to medical issues, and can articulate that the patient presented no reasonable threat to themselves or others, and they're also ANO4, have the capability of taking a refusal. Okay, so again, I'm repeating this a lot because it's super important. When are we going to activate RFD on a psychiatric patient? Well, if the de-escalation is unsuccessful, that's one. The second thing, if our findings for our history and diagnoses are abnormal, we activate Richardson. Or if we cannot articulate and that the patient's condition is not just due to a psychiatric condition. If there's something else that you suspect may be causing this, we're going to activate Richardson. Okay. And then the last one is if they are not displaying full capacity. So if they don't have the capacity to refuse transport. RFD activation, again, activate if you identify any other medical history causing psychiatric symptoms. If you're suspect of any of your differentials being present, again, if you think that they could be hypoglycemic, if you think they could be having a stroke, obviously we're going to go ahead and upgrade. Anytime you believe that medication intervention is needed, again, and sedation is probably going to be the course of action here. All right, so when does an APAL happen? The patient deemed to be a threat to themselves or others, that's a yes, we're going to get an APAL. So when the patient is cleared medically, but because of the psychiatric symptoms, could be a threat to themselves or others. They might be homicidal, they might be suicidal, we're going to go ahead and do an APAL. So, APAL, apprehension by a police officer without a warrant. Okay, UTD police, they're going to have a lot higher rate of APALs than most other departments. Okay, this is typical. We want to make sure that these guys are super important, and they know how to do it. Okay, they've been very, very well versed in getting APALs, so they can identify pretty easily when they need to do that. So the officer, for them to do it, must articulate that due to the patient's condition, they presented a threat to themselves or others. So the officer has to articulate this to be able to apprehend them against their will. Okay. So UEMR, EMS, we cannot take a patient against their will. All right. We're not in the business of kidnapping. However, the police department, they are able to, by state law, they can go ahead and take that. Okay. They go ahead and get that apprehension. For us to do this, we have to be cleared of any other medical history. Okay. Again, think of your differentials here. They have to be cleared of that medical emergency in order for them to be able to be cleared. And the officer will transport to an ER for a psychiatric evaluation. Essentially, once they have been APAL'd, they are in the custody of a police officer. It's like they have been arrested. Okay. Again, go back to our law enforcement release criteria and everything like that. We have to be able to articulate that they were free of medical emergencies, and that they had, they were a threat to themselves or others, and they were released of all medical sort of issues. The biggest thing here, guys, is we cannot release to law enforcement if we think there could be a medical issue going on. We have to be able to articulate that. All right, so we have an algorithm for this, releasing patients to law enforcement. All right, so the first thing, if we want to do an APAL, the police officer agrees to accept custody of the patient. If they don't, then we're going to infect RFD. If the police officer doesn't want to take him, they can go by RFD. Let's say they do accept it. We ensure a full assessment is completed, all differential diagnoses have been ruled out, in the provider's best judgment, no medical condition exists that could negatively affect the patient's health. So if we think all the normal assessment findings are there, the patient agrees to assign the refusal of ambulance transport form. Okay, sorry. Stop right there. Normal assessment findings, we're good. No medical issue. Abnormal assessment findings, we're going to activate Richardson. Okay, that's the first decision. Okay. The second one down here, this is where it gets a little hairy. The patient agrees to sign the refusal of ambulance transport form. So even though we're releasing them, they are essentially, because we'll give them the option still of going by ambulance. We're still going to offer that. If the patient wants to go by ambulance, they get to go by ambulance. The officer will go with them to hospital in the ambulance, but they get to go by ambulance. So they have to still sign the refusal of ambulance transport. That is really important because we're still offering them transport. Whether or not they go into the police officer's squad car or they go in the ambulance, the police officer will still escort them. Okay, but we have to know whether or not we want Richardson or not. So if the patient wants an ambulance, they get an ambulance. If they don't agree, if they don't want an ambulance, but they don't want to sign the form, okay, let's say they're just really mad at you and they don't want to do it, have the police officer sign the refusal of form as a witness and document it thoroughly. Okay, so the police officer signs as a witness. If they want to sign the refusal form, that's great. Get them to sign it, and then also have the police officer and sign it as well. Okay, so the police officer is going to sign the refusal as a witness every time for these ones as well. Okay. All right. So when can we get a refusal? Again, they're calm and collected. And the findings are normal in their history and assessment. Assessment is just due to the best thing is that we've ruled out every other medical history or issue, and then we have not deemed them to be a threat to themselves or others. We've displayed full capacity to refuse transport. We can sign the refusal of transport. So we have to be good, and good. All right. All right. Refusal of transport. We must be able to rule out any other condition other than the psychiatric issues. You see the repetitive nature of this lecture. That's because it's important. We have to have a full set of vitals, including blood glucose, including temperature. Again, why are we doing the blood glucose and temperature? Blood glucose because of hypoglycemia, temperature because of the possible infection. We have to have a full set of vitals. If you release someone on a psychiatric issue that did not get a blood glucose and temperature, then you need to make sure that you go back and do it, because we want to make sure we're doing a full assessment. If you didn't include a blood glucose or a temperature, you cannot articulate that you did a full assessment. We must be able to confidently say that the patient is not a risk to themselves or others. Okay, do we assess suicidal homicidal intention? Do we assess if there was any drugs? Do we assess if they're depressed? Again, we have to articulate very clearly that the patient's not a risk to themselves or others. We must be able to document the evidence that the patient was not a risk to themselves. Okay, this patient stated to us that they did not want to commit or hurt themselves or hurt others in any way. The patient displayed no signs of depression and no other signs that could potentially cause them to hurt themselves or others, or something like that. Okay, so kind of going back to that documentation still. What should we document? This, literally, 1 through 6. We're going to document. The patient displayed full capacity. The patient had no suicidal homicidal intentions. There was no evidence of self-harm or intention to self-harm. The patient does not meet any updated criteria. The police officer gave approval to the patient to be released. And a full psychiatric was completed as per UMR and Dr. Tice's clinical guidelines, policies and procedures, and is in the best judgment of the provider that does not present You have to say this entire thing. So when you are documenting a psychiatric call, look back at your refusal protocol and copy essentially what you did, and because you should have done all of this, and we document all of it. Okay, so this is the magic phrase that you should put in your report. It was in the provider's best judgment based on a lack of evidence and a full medical assessment that the patient was not a threat to themselves or others. Okay? Alrighty. So does anyone have any questions? If you do, if you're watching this after the fact, then email me. We'll put it in the group me, something like that. Again, guys, we have to make sure that you're super good to go on all this stuff. Okay. If you're taking this after the fact, then you'll have access to the quiz. Please go ahead and take the quiz, and we'll pause this right now, and then I'll go over the answers. So I'm going to pause it. You guys go take the quiz, and then we'll go over the answers together. Alrighty, so if you've taken, I hope that you've taken the exam, and we're going to go over each question. Okay, so question 1, the answer is going to be C. All right, we have to rule out life-threatening conditions that may be masked by psychiatric symptoms. Okay. All right, so question 2. Following the unsuccessful attempts at de-escalation, what does the algorithm say to do next? Okay, again, this is going straight back to the algorithm. Okay, activate RFD. All right, so anytime again we can't get de-escalation, we're going to go back to the drawing board per se and see if we can get RFD en route. Question 3: how can de-escalation affect our patient assessment? Okay, this is a free response question. Okay, so your answers should include It gives us better access for the patient assessment, improves team safety, and there's more reliable answers. We can talk easier with the patient. We can assess them so much better. Okay. Question 4. What were the 3 techniques that were discussed regarding verbal de-escalation? Okay. Again, focus on history and assessment, giving choices, setting limits. Those are the 3 things. This is really important, guys, that you really understand that verbal de-escalation and understand that it's an escalation thing. We start with focusing on the history, we start giving some choices, and then we set our limits. All right. 5. What were the 3 physical signs that would be most concerning when ruling out Cushing's triad and a head injury? Again, straight off the PowerPoint, a decreased heart rate, increased systolic blood pressure, and decreased respirations. If you guys don't understand what Cushing's triad is, go and it's in the textbook. Go look it up online. Get a good understanding of what that is. There's way too much for us to cover in this video, in this lecture, but we want to make sure that we're doing and understanding what Cushing's triad is. Alrighty, number 6. Briefly describe the process of assessing suicidal and homicidal patients. Okay, again, step 1, ask them. Step 2, find out their plan or immediately request PD depending on the answer. And step 3, ensure there's no evidence. Okay, we want to make sure they didn't execute their plan. Question 7. What is the criteria for an officer to conduct an APAL? Again, the officer has to articulate that the patient is a threat to themselves or others. And question 8, according to the algorithm, there are 3 instances where RFD should be activated. What are they? Again, go back to the algorithm. Abnormal assessment, medical concern, patient does not have capacity, or de-escalation is unsuccessful. And question 9, question 9, you're in the process of releasing a patient to law enforcement custody. If the patient will not sign the refusal of transport form, what should you do? Ask the officer to sign the refusal as a witness, document badge number. Okay. Again, we want to make sure that we're getting good transfer of care documentation. Make sure that they sign as a witness. And then 10. When conducting a refusal on a psychiatric patient, what must a provider be able to document on the PCR? Again, we have to articulate that the patient was not a threat to themselves or others. Okay. And that after full assessment, there was no issues of, after full assessment, the patient does not present a threat to themselves or others, and the provider's best judgment, there's a lack of evidence showing that it was a medical emergency or something like that. Go back to this right here, and it was in the provider's best judgment, based on lack of evidence and a full medical history, that the patient was not a threat to themselves or others. Okay. Alrighty, guys, well, that's it. I hope you guys enjoyed it. If you have any questions, let me know. Does anyone have any questions? No? All right. Well, let me know and email me if you do.